webinar of the newly formed WFNS committee. I'm happy to say that Nikolay Peev is a chair with co-chair Fatos, and he was also formerly a chair of Innovation and Technology Committee of the World Federation of Neurosurgical Societies. He has been a treasurer of the World Spinal Column Society and editor-in-chief of International Neurosurgical Journal. He is very voracious writer, reader, and keen trainer, and of course, master surgeon. So I'm very interested in your topic because you say that everything does not have to be MIS, but I want to listen to you. Please tell me.
Thank you so much for the great introduction. Let me try to share my screen. I have maybe problem to share my screen. Let me see. So okay, so I'll start my presentation. Okay. For some reason, I have problem with my open system setting. Okay, can you see my screen?
No.
Okay, so I will just reopen the meeting in a second.
Yes, you may have to come out and log in again. Thank you.
Have active participation, please bring your ideas or your cooperate and collaborate with the Spine Committee of WFNS in your national or regional activities that we can exchange the presenters and in the name of the World Federation of Neurosurgery. So Nikolay is present.
I am okay. I think I can do that now. I see my screen. Can you see my screen?
Yes, it's okay.
Okay, perfect. I'm going to talk. Thank you so much for your introduction again, and it's great pleasure to be with you and to start the first of the series of webinars of the Spine Committee of the World Federation of Neurosurgery. I'm going to talk to you about the minimal invasive spinal surgery and deformity surgery, and whether it can replace the open surgery. So. A quick slide to show you historically how the different surgical techniques were developing. You can see that we have the first PLIF around early 50s. And we have the first TLIF through tubes in the early 2000s. So really after 2000, we started developing minimal invasive surgical techniques. And after that, we have seen a really big expansion of minimal invasive techniques. You can see on that left side of this table the pathology that we are treating, and then the open technique, and then how many, at least to any one open technique, we have at least a couple of minimal invasive techniques available now. So minimal invasive techniques are really developing quick. But before I continue, let me just be a little bit philosophical and maybe give a definition of what is surgery. Surgery is a process that we have to define a surgical target, and we have to reach a surgical target by developing a surgical corridor. But by developing that surgical corridor, we normally destroy normal healthy tissues. And so our strive is always to reduce the damaging of the normal tissues that we have to go through to reach the surgical target that is deep. So, and the minimal invasive surgery is a natural continuation of our strive to reduce that damage of the normal tissues. So leave less footprints as we operate. So, and that slide is one of my favorite slides. I always show that slide when I speak about minimal invasive surgery. If I ask you if that is to be your end point on your own back, and if you have to choose, if you have to go through that stage or through that stage, I'm sure what you're going to choose. So it's no brainer that minimal invasive surgery is beneficial, and we have to try to introduce it in our practice and to perform it for our patients' well-being. So if you go to PubMed, and if you do a simple search, minimal invasive spinal surgery, you can see that since the early 90s, when the minimal invasive surgery started being a thing and started being reported, there is almost exponential growth of publications about minimal invasive techniques and surgeries. So will minimal invasive surgery replace the open surgery when we operate deformity patients? Unfortunately, the current state of the art, the current state is that we are still not quite there yet. We still need the open surgery if we have to do really extensive approaches and if you have to do big deformity correction. So traditionally, the open surgery is the most common approach for deformity surgery, but unfortunately associated with extensive muscle dissection, ligamentous releases, osteotomies, and finally neural decompression. However, this is, of course, very invasive. And unfortunately, the global trend now is that most of these patients which have to be operated for with this type of surgery are elderly patients with significant comorbidities, with poor nutrition. And so as a result of this significant risk of complications, as per some publications, up to 80% of the patients with following deformity surgery might develop complications. So the natural answer to that is the minimal invasive surgery that is potentially reducing the risk of complications. So minimal invasive surgery with regards of the deformity can be involved at different extent. So you can do direct decompression, you can do indirect decompression, you can do circumferential minimal invasive surgery, so front and back, or you can choose to do hybrid solutions. So minimal invasive is shown to have potential in deformity correction surgery, but the degree of the deformity correction is still, unfortunately, we have to admit, is inferior to the open surgeries when we speak about extensive deformity correction. So a few papers that are showing that. Anand and group retrospectively followed about 90 patients. In 2016, they have published, in 14, they published that paper, and they report on so-called ceiling effect. They found that their limit is about 61 degrees of coronal correction, and maximum of about 9 centimeters of SVA correction. So regarding the pelvic incident lumbar lordosis mismatch, they were possible to correct to the desired 10 degree only if the pre-op mismatch is less than 38 degrees. So similar results are reported by other researchers, like Mundis reports the same ceiling of 50 degree coronal cup angle correction, and sagittal balance is restored in 9% if the SVA is over 9.5 centimeters. So similar to the previously reported 9 centimeters. And the benefit for the benefit is mainly for the moderate deformity with SVA 4.5 to 9 centimeters. And they found that even if they don't restore the pelvic parameters to the desired degrees, patients are still having improvement of their quality of life. So there is probably other factors as well. So in order to bridge the gap between the minimal invasive and the open surgery, there is different techniques that researchers are being developed. And one of the most popular is the anterior column realignment technique, which is basically anterior longitudinal ligament release and use of hyperlordotic cages. So the same authors which researched the minimal invasive and open with respect of the deformity surgeries reported that if they apply the anterior column realignment instead of PSO techniques, they have similar radiographic correction, but less blood loss, nearly also more than half of the blood loss is reduction with more than 50%. Wang and authors the report on mini open PSO and adapting minimal invasive techniques to reduce the collateral tissue damage when they address 3 columns. And they have achieved also similar correction, but with less invasiveness and with less chance of complications. So another interesting paper I have found when I was studying the topic, Haag and Mundis, 184 patients comparing minimal invasive versus hybrid versus open. And they found that the minimal invasive sagittal correction only 13%. So minimal invasive is inferior comparing to hybrid, comparing to open. The PI-LL mismatch correction, interestingly, hybrid group is the best, but very interestingly, no difference between the groups with respect of ODI and VAS scores between the 3 groups at 1 year mark. So Paul Park, similar results. So obviously this is consistent and reproducible. Another thing that we have to mention with regards of the minimal invasive is the healthcare rising costs and the need of more and costly equipment when you have to do minimal invasive surgery. Of course, yes, you need to buy new technology in order to start minimal invasive approaches. But there is a lot of publications now that suggest that this should be taken as investment, as this will later offset the cost by lowering the complications, lowering the blood loss, reducing the hospital stay. And there is publications that report that the cost effectiveness of the minimal invasive surgery is significantly better comparing to the open surgery. Other factors that also are on the way of the minimal invasive surgery becoming mainstream option, long learning curve. We are all talking about long learning curve. We are talking about steep learning curve. So I'm going to say a few words and I'm going to explain what exactly is that long and steep learning curve. There is research with that respect as well. Pereira and group from Portugal studied how many cases do you need roughly in order to get a minimal invasive technique in your practice. So they found that if you do 50 cases of a new minimal invasive approach, you are probably reaching about 90% of your milestone. So if you want to get 100%, you have to double your cases. That's why the learning curve is steep. From 0 to 90%, you went with 50 cases, but in order to go to 100% milestone, you have to do another 50 cases. So you double your cases, but with 100 cases, you are still not expert. You need to double your cases again. So at about mark of 200 cases, you probably are experts with that technique. So this is why minimal invasive, unfortunately, is not getting into practice as fast as we want, because it's more demanding and you need more to develop and to introduce it in your practice. It was already discussed by Roger Hartle, the use of radiation or not. Yes, in some centers there is high-tech possibilities that you can use and skip the radiation and not use X-ray with your minimal invasive techniques. But in most of the centers, still the fluoroscopy is used. And in some centers, as we heard, deliberately. So some researchers report that they have actually better results and faster and shorter operating times only with fluoroscopy comparing to the navigation. So you still have to consider the X-ray. And if you are working with X-ray, you have to study how to protect yourself, because you have to bear in mind that you are going to work with that for a long period of time, and you're going to accumulate a lot of radiation, and maybe you will have harm. So you have to study how you protect yourself from radiation, and choosing a specific position in the OR with respect of the tube can significantly, as you can see, reduce your radiation exposure. So you have to be wise with the X-ray if you're using it. Another thing that you have to consider is that even 20 centimeter distance between you and your patient will significantly reduce your dose. So you have to try to develop techniques that are not requiring you to hold the instruments. Minimal invasive special equipment, yes, you need that, but if you think out of the box, quite often you can be inventive, and you can still apply minimal invasive surgical techniques in your everyday practice without having the fancy instruments. So this is, for example, the first table that I started using when I started doing my first minimal invasive TLIFs, and it was working okay. Yes, I like to have the fancy tubular retractors, but the first retractor that I was using is the simple McCulloch retractor, and I'm going to show you a few slides of my practice. Sometimes I still use that, and I actually quite like using it because it's less restricting, but I'm going to comment on that later. So this is the view that I was seeing with the McCulloch retractor with these settings. One side hook, one side blade, and you can see that you can still perform minimal invasive approaches. And so that's how I was doing my first minimal invasive cases. And you can see that is still allowing you to do a very good decompression. This is central dura, this is the traversing, this is the exiting nerve root, this is the cage. So this is the view after I have done a minimal invasive TLIF with that setting and with that retractor. Something else that I would like to show you that I think is helpful and is very cheap. As Fatos mentioned, that we have to try to bridge the gap between the high-tech and low-tech centers. But this is something very simple that you can use. This is a sputum container, for example, that you can find in every ICU. This is a container that will help in ICU to collect the sputum from patients which are intubated. But I'm using it to collect bone dust when I'm drilling. And so this is what's happening. You connect your suction to the inlet, and then you collect the tube that is going to the suction pump to the outlet, and like that you have a system that will collect the bone dust when you're drilling. And then when that's full with bone dust, you put it in a swab, and then you squeeze it, and then you have a very nice amount of bone dust that you can fill your cage, and you have a good quality bone that will help you with your fusion. One point, I drill always with matchstick head, but not with diamond, because the diamond will be very fine the bone dust will be very fine, and also the temperature will kill the osteoblast. So if you're planning to use that technique, use the matchstick or something else which is not diamonds. So another thing that is a tip from my practice, which I wanted to share with you, is the traditional, and it was mentioned before, the nerve roots at risk. The traditional technique, for example, for minimal invasive TLIF will be pedicle to pedicle facetectomy. That was what I started in the beginning. However, I have progressed later to partial facetectomy, and I'm leaving that overhang. You can see this is the cranial, this is the caudal, medial, lateral, this is the exiting nerve root, and I see an overhang of a bone in order to protect the exiting nerve root, and that's the way I do it with the 4 cuts. This is the proximal cut, which is aligned to the disc. This is the cut that is towards towards medially, and this is the cut towards the lower pedicle, and that is how it looks after you have removed the bone. So you have this overhang that is protecting and is creating safe space for your exiting nerve root while you're driving all these big instruments. And like that, I have managed to reduce significantly my nerve roots compromise, to an extent that I don't remember when was the last one that I had as a nerve damage. Probably the last one, thankfully, for me years ago. So this is how it looks like on the X-ray. You can see the caudal cut with the osteotome. You can see the proximal cut with the osteotome, which is aligned to the upper end plate, and this is aligned to the pedicle. And like that, you have the overhang of the bone with the partial facetectomy, and you have the safe space for your exiting nerve root that is nicely accommodated in that safe space while you're driving your big instruments and the cage. Something that will be helpful for you with that technique, even if you have very compressed disc, very collapsed disc, instead of doing full facetectomy, if you do partial facetectomy and you cone it like that, the cage itself is distracting for you. But in order to accommodate the cage in that tight space, sometimes you need to take the edge of the caudal vertebra. And this is how it looks like on X-ray. You can see the K-wires. I still use K-wires sometimes, although I have the 2nd generation minimal invasive screws, which are without K-wires. But I like to use the K-wires. And this is the settings. You can see the blades with the McCulloch retractor medially. Laterally is just the hook. And that gives you that extensive view while still you're performing minimal invasive surgery. You can see that this is the medial, this is the lateral, this is the cranial, this is the caudal, and you can see everything that you need: inferior articulating facets, superior articulating facets, and TP. So this is where you perform your surgery. And lastly, with that technique, maybe somebody thinks that it's more invasive than the tubes, but if you do a simple calculation, you can see that if the blade is 20 millimeters, which is 20 millimeters, and if you extend to 25 millimeters, simple calculation is showing you that the footprint of that construct is equal to 18 millimeter tube. But quite often, I don't need to go to 25, I go just to 20. And in that case, if you do the calculations, you will have 60 millimeter tube, while you don't have the restriction laterally and also medially because of the hook. So you can do wider decompression without need of moving your tubular retractor. So that was it from me. My last words. The gap between MIS and open surgery is getting smaller and smaller. And I'm sure that we're going to see a moment when the minimal invasive will be the mainstream for everything we do. Try to accept minimal invasive spinal surgery not as a type of surgery, but as a philosophy. And even if you can do some certain steps of your surgery as minimal invasive, try to do that, because that's still going to be beneficial for your patients. And thank you so much for your attention.
Thank you very much, Nikolay. Very well demonstrated. You have convinced that minimally invasive way is the way forward. However, I would like to ask you first before I pass on to my fellow co-chair and for the general attendees, where would you still see a place for standard open surgery? That is the first question.
So, if Pragnesh, in my practice now, I have started in 2017. I started developing endoscopic approaches. In 2016, I started developing these minimal invasive surgeries. And to be honest with you, I see open. I don't do much deformity surgery. I do adult deformity, but I don't do extensive deformity surgery. And to be honest with you, I'm trying to do everything with minimal invasive. I very rarely do open approaches lately.
And if, on the other hand, if someone who is traditionally taught and trained for an open procedures, what would be the first one you would say if you want to switch on to the minimally invasive ones?
Yeah, so I'm working actually on publication on that. So I would like to, I'm working on publishing a paper on how do you get a new technique. And my idea is that getting a new technique in your hands and how soon and how fast and with what means you can get it is very much dependent on where are you at your journey. If you're experienced surgeon, if you're a surgeon that is well aware of the open techniques, if let's say if it's doing minimal invasive techniques, then probably it will be way easier for you to get a new technique in your hands comparing to somebody that has just graduated, somebody has just passed the residency program. So in general, as a standard is, if you would like to develop, let's say, a minimal invasive practice, and if you are starting that practice just now, if you are just graduated, you probably have to go and stay for a year or two with somebody who is doing that already in a form of fellowship. But if you are experienced surgeon, then maybe you can attend courses and then slowly you can introduce different elements, and later the complete surgical practice could be minimal invasive.
Thank you very much. I tell you from my own personal experience, I did an orthopedic spine fellowship very late in my career, and I was trained to do most of this in open, but I subsequently learned to start with a percutaneous pedicle fixation in a thoracic fractures, and then I took it further to the metastatic spinal cord tumors. So I can correlate to what you are saying. My only feeling is that I think in the craniovertebral junction surgery, still there is a lot more to go with. I know there are experts who do it minimally invasive with the tubular retractors, etc. But I think craniocervical junction with very delicate neurovascular structures would be the last one where we will be able to replace open with minimally invasive.
I agree with you. On one hand, yes, this is the case, but again, everything is dependent on how much experience you have. So I would like to. So my philosophy always is that the impossible things are the possible things which take longer.
Yeah. Can I make a comment?
Please.
Thank you, really. It was a very nice discussion. I thank Nikolay as well. The probably rigid and complex deformities are still a bit far away from minimally invasive surgery, especially the osteotomies. Although there are few papers in the literature describing how to make a minimally invasive osteotomy, but in general saying the deformity surgeons don't like to use MIS in osteotomy and complex deformities. But shorter fixations can be done with percutaneous techniques. If the levels are too long, then insertion of a rod is not easy, and the correction maneuvers are not that much easy. Okay, this is my comment.
That's very helpful comment. Are there any other questions before I hand over mic to Fatos for his expert comments and conclusion? Thank you.
For Nikolay, do you believe the current minimal invasive technique compromise correction in favor of reduced complication and morbidity? In my opinion, is that the correction and the fuse, it will be difficult with minimal invasive.
Yeah, I agree with you, Fatos. Again, everything depends on your personal experience and how does the specific technique is working for you. One of the papers that I presented was about that ceiling of correction. So that's, these papers are coming from very experienced in the area minimal invasive spinal surgeons, which are reporting on ceiling of correction, and they reported us about 50, 60 maximum degrees of correction with minimal invasive techniques. And if you have to do more extensive corrections, then obviously the open techniques have to be used. So yeah, if this is the numbers that are reported by these high volume expert surgeons, then probably somebody that is not as experienced will reach the ceiling way below this 50 degrees. So in that respect, you're absolutely right. So you have to know your limitations. You have to see how that technique is working for you, and if you are compromising the definition of the minimal invasive surgery is a surgery that is using techniques that spare the collateral damage but still reach the end point. So if you are not reaching the desired end point, then you're not doing a good job. So you should not be doing the minimal invasive surgery. You have to go open.
Yes, thank you.
Yeah, okay, so seems like our third speaker is not here.
Yeah, maybe some cases
something
in
unexpected.
operation, some unplanned.
He's normally disciplined, and we had him before in other webinars, and it is not typical for him to not be here, so probably something unexpected. I hope we will involve him in our future webinars.
Yeah, sure.
Okay.
Other question or a discussion or? Professor Zileli, you want to?
I think no, this is fine. I think we can end the session here, and then invite everybody to our future panels.
Okay.
Thank you all the moderators and all the speakers for their very nice talks and very nice discussion.
Thank you
so much.
for